Okay, thank you, Sahib. I'm going to talk about advances in management of relapsed refractory multiple myeloma. Next slide, please. Next slide, please. Yes, simply I'm going to talk about which option do we have to rescue multiple myeloma patient at first relapse. And at the same time, I will tell you how to proceed in clinical practice and how to make the right choice. Next one, please. Okay, to start with, what is the definition of relapsed and refractory myeloma? In fact, this should meet with International Multiple Myeloma Working Group criteria for disease progression. As you can see in the right side of the slide, that is where IMWG criteria for disease progression with equal or more than 25% increment from nadir in serum or urine M protein, difference between involved and uninvolved free light chain levels, bone marrow plasma cells, or presence of new lesions or circulating plasma cells. This indicates actually disease progression. Back to relapsed and/or refractory multiple myeloma, defined as a progression on therapy in patients who obtain equal or more than minor responses or progress within 60 days of most recent therapy. Primary refractory multiple myeloma can be defined as progression on therapy without having achieved at least minor response. Going back to relapsed multiple myeloma, meets International Multiple Myeloma Working Group criteria, as we mentioned before, for disease progression, but does not fit definition of relapsed refractory or primary refractory multiple myeloma. I hope I did not confuse you with these definitions. Next, please. Next slide, please. Yes. Now thinking about what are the strategies at relapse and how to make the right choice. Sometimes it's not straightforward and not easy, but however, we have to, first of all, to think about the type of relapse. And this means that we have to think whether the patient relapsed early or intermediate or late after the first line of treatment. Early, that's mean within 2 to 3 years, intermediate, 3 to 5 years, and late after 5 years. Of course, we have to keep in mind about the toxicity of the previous treatment, especially peripheral neuropathy with proteasome inhibitor, and other criteria and further options. I'm going to elaborate on that. And to keep in mind what was the efficacy of the previous treatments and the duration of response. This is really very important. Next slide, please. Here we can say that key clinical consideration at relapse. We have to look at the patient for certain things as written down, as well as disease and molecular assessment. Then prior treatment, whether autologous stem cell transplantation, proteasome-based, or IMiD compound-based, or alkylator, whether the patient had maintenance or not, and response and tolerability with progression-free survival, response to prior therapy, and so on, adverse events. Next, please. This is just to start with, actually, this is the ESMO guidelines, 2017, in relapsed refractory multiple myeloma. First relapse, actually, they divided the patient into two groups, whether IMiD compound-based induction or bortezomib-based induction. In patients with IMiD compound-based induction, they will benefit from proteasome inhibitor-based doublet like KD or VD, or bortezomib-based triplets in form of DVD or Banu-VD or EVD or VCD even. In bortezomib-based induction, we have to change the class of the medications into IMiDs and use RD doublet or if we shall use triplets, will be DRD or KRD or IRD. Next slide, please. Here are just the new guidelines necessary for the current population, because you know multiple myeloma treatment is changing from year to year, and there are new medications on and on going on. And luckily, there is an excellent trials going on to reach really not only treatment for multiple myeloma, but cure of multiple myeloma, which is still to some extent far away at this stage. First relapse after proteasome inhibitor or and IMiD-based induction and lenalidomide refractory disease will be depending on shall we use daratumumab-based regimens or no daratumumab-based regimens. If we shall choose the first group, we shall give VD with daratumumab or KD with daratumumab or KD with Isatuximab, which is again anti-CD38 monoclonal antibodies, same as daratumumab. Or might be proceed with actually pomalidomide, which is the third generation of the IMiDs, and dexamethasone with or without daratumumab. On the other hand, for non-daratumumab-based regimens, we can use IMiDs third generation with proteasome inhibitor and dexamethasone, or might be again pomalidomide with cyclophosphamide and dexamethasone, or pomalidomide, dexamethasone, and Carfilzomib. Or to go ahead with the new medications like VD selinexor, VD venetoclax, and KD with cyclophosphamide. However, the last group is still under trials, but there are encouraging results, and in the near future going to be available. Next slide, please. Here, the management of first relapse in more details, actually. After the first line, bortezomib-based combination with no maintenance, patient will go for either doublet or triplet. At this stage, actually, doublet is not more any encouraging regimen to be given, but triplet based on RD, yes. And to give daratumumab with RD or Carfilzomib-Rd or Ixazomib, which is oral proteasome inhibitor RD, or Ixazomib, again, monoclonal antibodies with RD. And to confirm the benefit of this combination, we can look at the number of studies, for example, POLLUX, ASPIRE, PLIC-1, 2, or Tourmaline MM1. For example, if we shall look at the POLLUX, we can find out here the efficacy in form of progression-free survival and 95% confidence interval. We can find 0.44 with really 44.5 months versus 17.5 months, with overall response rate 93% and duration of response not evaluable. At the same time, overall survival hazard ratio 0.63 with 37%. In ASPIRE's study, which KRD, Carfilzomib-Rd versus RD, showing also some improvement in form of progression-free survival, as well as the CRR and duration of response, and also overall survival hazard ratio with 0.79 and overall survival 48 versus 40 months. In PLIC-1, where Ixazomib in combination with RD compared to RD, also there is some benefit, as well as Tourmaline MM, in which the oral proteasome inhibitor Ixazomib added to RD and showed to some extent an improvement. Next slide, please. Here, just to elaborate more about the POLLUX study in which daratumumab added to RD versus RD, and you can see here that the median follow-up is 54 months. And if we shall look at the intention to treat population, we shall find that those patients treated with DRD, daratumumab in combination with RD, they will have median 45 months, comparing to the Control arm with RD only 17.5 months, i.e. progression-free survival was prolonged with DRD versus RD in patient receiving one prior line of therapy, and the median 53.3 versus 19.6 months. Not only that, but also in patients who were refractory bortezomib showed some improvement, and the median 34.3 versus 11.3 months. If we shall look at the standard risk median, we shall find that 52 months versus 18.6 months. Not only that, but also high risk median showing really good comparison in which the combination of Dara-Kd showed 26.8 months versus only 8.3 months in the control arm. That's mean 56% reduction in the risk of progression or death in patient receiving Dara-Kd combination. Next, please. Here, tourmaline MM1, where the oral proteasome inhibitor Ixazomib added to RD versus RD in relapsed refractory multiple myeloma, where we can see here the median progression-free survival with IRD combination 20.6 months, while in the placebo RD showing only 14. Next slide, please. Here, Carfilzomib, which is a proteasome inhibitor, combined with lenalidomide and dexamethasone, again, versus lenalidomide and dexamethasone. This is the ASPIRE trials, and showed really overall response rate 87.1% versus 66% in favor of Carfilzomib-Rd combination. Not only this, but also there are more CR in 32% versus 9%. And as you can see in the graph, progression-free survival also it is significant with high p-value, high significant p-value. Overall survival, even though it is not highly, it is really significant in favor of KRD. Next one, please. Here, there's just management of first relapse, bortezomib-based combination, followed by treatment-free interval, exposed to lenalidomide and or progressing under lenalidomide therapy. That's mean lenalidomide refractory. So we can use doublet, but using actually Carfilzomib proteasome inhibitor or triplet, and this is more favorable actually. Triplet based on bortezomib with daratumumab, Velcade, and dexamethasone, or even DCD. If we shall look at the trials to convince ourselves about this, we can find Endeavor trial comparing KD versus PD in relapsed patient, actually, because we heard Dr. Hanbali told us about the KD versus PD in the induction, there was no difference. But in relapsed patient, there is some favor for the Carfilzomib dexamethasone versus Velcade dexamethasone, with a progression-free survival 18.7 months comparing to 9.4 months, with overall response rate 77%, and overall survival 47.6 versus 40 months. On the other hand, CASTOR trial where daratumumab VD comparing to VD showed really improvement, in which the progression-free survival 16.7 versus only 7.1 months in the control arm, with overall survival 85. And the good thing about this really combination, they reported negativity of minimal residual disease in 14%. Next slide, please. Here, they really, when daratumumab added to Velcade Dexa versus VD, and this is the CASTOR trial updated efficacy for progression-free survival. Definitely there is an improvement with intention to treat population graph, as you can see, at 48 months progression-free survival rate with 16.7 median months comparing to 7.1 as we mentioned before. More elaboration on that actually, progression-free survival was prolonged with DBD versus PD. In patients receiving one prior line of therapy, median 27 versus 7.9, remarkable improvement. In patients who were refractory to lenalidomide, median only 7.8 versus 4.9. In patients with high or standard cytogenetic, also there is a difference with actually 16.6 comparing to 6.6 months in the standard risk median and 12.6 versus 6.2 months in high risk median. i.e., there is 69% reduction in the risk of progression or death in patients receiving DVD. Next, please. Here, Endeavor trial, when it is compared KD versus PD in more elaboration with improvement in progression-free survival as well as overall survival. Next one, please. Okay, this is the optimism multiple myeloma trial. When this is the lenalidomide in combination with VD compared with VD in relapsed refractory multiple myeloma patients, but after first prior line. And the number of the patients in this trial was very good, 559 patients with median 2 prior lines of therapy, and 100% lenalidomide exposed with 70% lenalidomide refractory and 63% lenalidomide refractory as part of the last line of therapy, still showing some really improvement in the pomalidomide VD arm comparing to VD. Even the p-value is only 0.2 with hazard ratio 0.55. In lenalidomide refractory, but in lenalidomide non-refractory patients showing really p-value is borderline 0.49. Next, please. Next, okay. This is a new findings in later relapse in multiple myeloma when they are using the second drug monoclonal CD38 monoclonal antibodies, Isatuximab, combined with pomalidomide and dexamethasone. This is the CARIA phase 3 study. Compared ISA, pomalidomide, dexa versus BD. As you can see from the slide, the response is really very good, in which the overall response rate 60.4% versus only 35.3% in the control arm. And in fact, the addition of ISA to BD resulted in significant improvement in overall and depth of response. Next one, please. Next. So again, more elaboration on the Isatuximab-Pomalidomide-Dexa, the median follow-up 11.6 months, but is still showing some progression-free survival improvement with 11.5 months comparing to 6.4 months and highly significant p-value. Not only that, but also overall survival improvement. However, both actually arms are still the median not reached in either treatment arms. Significant clinically meaningful improvement in progression-free survival consistent across subgroups. Next one, please. So this is a very good study actually in which the antibodies Dara-Kd combined with second generation proteasome inhibitor and dexamethasone versus Carfilzomib and dexamethasone. This is called CANDOR study. And the patient number is 466. And it was randomized to 2-to-1 with in KDD, 2-to-1 in KD. And the good thing about this, actually, they monitor minimal residual disease at 0 time, at 12 months, as well as 24 months. Patients were treated until treatment and until disease progression. The primary endpoint was progression-free survival, and key secondary was overall response rate and minimal residual disease and overall survival. Next one. Okay, next slide, just for the sake of the time. And we can see here really the result, actually. Primary endpoint met, where Carfilzomib, Dexa, and Daratumumab significantly prolonged progression-free survival compared with Carfilzomib Dexa alone, as you can see in the paragraph. Also, the median progression-free survival not evaluable at the same time in KD only 15.8, with hazard ratio 0.63, and p-value showed highly significant 0.0014. Next one, please. This is just the hazard ratio across specified subgroup. Next, please. And this is again pointing about the cytogenetic risk group, in which the KDD patient in that arm did better than the KD group. Next one, please. And this is here the response rates. And we can see really on all levels, whether overall response rate or very good partial remission or better, or CR or better, or KDD are patients doing better than KD, better than the other arm with KD, with highly significant p-value. Not only that, but also deep response, in which actually minimal residual disease reported in 12.5, comparing to 1.3 as negative, with highly significant p-value 0.001. Next slide, please. This is the overall survival. Probably there is no significance so far, but we have to observe more and to wait more. Next slide, please. This is just telling us the common adverse events with, as you can, the last one, pneumonia, infection is more in the KDD arm. Next one, please. This is very interesting slide because the adverse events of interest here. Why? Because acute renal failure, you can see the KDD arm is less comparing to the KD arm, where the KDD showed 2.9, grade 3 or more, while in the KD alone, 6.5. Not only this, but also the cardiac failure reported more in the KD with 8.5 comparing to KDD 3.5. It was not explained. However, they are thinking about might be some protective mechanism when we are combining Carfilzomib with dexamethasone and Dara. Next slide, please. This is the most common reason for fatal events. Actually, it was really infection and cardiac disorder. However, we have to keep in mind that patients with fatal adverse events on the KDD arm were generally older and more frail. Next, please. So, in short, we can say that strategies at relapse, how to make the right choice when we are looking at the intermediate relapse, no comorbidities, no residual toxicity, maintenance with lenalidomide. If there was no maintenance, actually, RD-based combination preferable. However, if the patient treated with maintenance, we have to look at the relapse time, whether early or late. In early relapse, Pomalidomide here is choice-based combos, whether in addition to monoclonal antibodies, in addition to cyclophosphamide and dexamethasone and so on. Not only that, but also Carfilzomib-based combos, also with Dara-Kd, with other new medications. Here is very interesting, really. CAR T-cell can participate here. However, we have to keep in mind that CAR T-cell therapy is not yet approved by FDA in the treatment of multiple myeloma, even though there is very encouraging result actually, and high reported cases of negative minimal residual disease. I believe within a short time going to be approved in multiple myeloma, like for example in ALL and diffuse large B-cell lymphoma. Other new monoclonal antibodies on board and actually giving like bispecific and conjugated monoclonal antibodies, giving really very encouraging result, but we have to wait. On the other hand, if the patient relapsed late, that's mean 5 years and beyond 5 years, we can use actually monoclonal antibodies in combination with proteasome inhibitor and dexamethasone, or simply Carfilzomib and dexamethasone, but probably the preferable combination is Carfilzomib and Dara-Kd and dexamethasone. Also, we can use pomalidomide VD or Dara-Kd, pomalidomide, dexamethasone. Next one, please. So this is the conclusion when we are talking about relapsed refractory myeloma therapy. At relapse, multi-drug combination incorporating new agents can provide maximum benefits, but to keep in mind that triplet regimens preferred, i.e. 2 drug classes plus steroids with at least one agent class than previous treatment. Even minor responses have clinical value in relapsed disease. Because no therapy is curative in multiple myeloma, all options need to be tried sequentially. However, there are no data on optimum sequence of regimens for relapsed refractory disease at this time. Patients should be treated to achieve best response while taking into account potential adverse events and maximizing supportive care. There are promising new agents in development, and patients should be encouraged to participate in clinical trials, for example, CAR T-cell or monoclonal antibodies. Next slide, please. Just before I will close, really, I will just mention about the goal of therapy in multiple myeloma. Even though Dr. Hanbali told us that negative minimal residual disease or undetected minimal residual disease is not yet approved to be the monitoring tool. However, now they are encouraging all the new trials of multiple myeloma, minimal residual disease should be included, because what they are thinking about that undetectable minimal residual disease, when it is done by flow, next generation flow and sequencing, next generation sequence in combination with imaging CT scan and reported to be undetectable, that probably will lead to operational cure. However, having mentioned that, actually, in CAR T-cell therapy, one of the patients actually achieved complete negativity of minimal residual disease, but unfortunately relapsed. So by saying that, actually, we have to use sequencing, switch of class, new combination at first relapse. Yes, we are facing some difficulties like efficacy, safety, comorbidity, treatment goal, but we have to try to do our best for this an incurable disease. Thank you for your attention. And now, is there any questions or opinion or argument? Please.
Yes. So, Doctor, please let me announce that Dear doctors, you can unmute yourself. You can use your mic to ask any questions for Dr. Fahd. If you have any question, any clarification that you want to address it to Dr. Fahd, you can either write it in the chat box or open your mic, unmute yourself, and ask it directly to Dr. Fahd. Thank you.
In fact, we have 5 minutes for these questions and or opinion. And most welcome anybody